Dr. Thomas will speak to us on primary angle closure suspects. So, should you do a laser peripheral iridotomy or not?
Thank you, Kiran. In angle closure, we have what we think is a primary mechanism as a relative pupillary block. Iridectomy or iridotomy would take care of the pupillary block, so laser PI being easier would be the way to go. But do we need it? Does it work? Especially at the PACS stage where the patient actually doesn't have a problem yet. PACG, there's no problem, we need to treat the fellow, and closure primarily needs surgical treatment, so PI would be the way to go. The data we have always had is the Valorai survey. 22% of the PACS suspects progress to primary angle closure, not yet glaucoma, in 5 years, and 11% of the PAC angle closure with Sinike who underwent PI still progress to PACG in 5 years, and 36% of those who refuse PI progress to angle closure. So what it shows is PI doesn't deal with the closure element fully, and those who have PI seems to be somehow a little better protected. Chennai glaucoma survey also, the incidence of primary angle closure was deemed as 4% in 5 years. Those deemed normal in 5 years became PACS or worse. And 87% of that was only PACS. So, incidence of PACG is low in PACS and PAC, and PI does not protect them all. This is something we always knew. But now we got more recent studies, a couple of them, which have actually given us data, like an experimental data. And the first of them is Zhongshan, I don't know how to pronounce it, angle closure prevention trial ZAP. It screened a large number of subjects, 11,000. 870 of these subjects were enrolled. PI in one eye and the other eye as control, and 6-year follow-up. All subjects are from South China, so ethnically not the same as us. And PACS, the limitation here is they will not use indentation gonoscopy, 2-quadrant or pigmented trap not visible. There's a posterior trap not visible, and no Sinike or disc changes, and intraocular pressure should be less than 21. Those excluded were on provocative tests if the pressure went up, or on dilatation the pressure went up, or 30 mmHg at any point in time. They were sent into the standard of care, which is PI. Of these patients, about 454, they had OCT data, and they found that 26.4% had residual PACS. That means 1/4 of the patients who went through PI did not open up. And they came up with report as per 1,000 years, 4.19 per 1,000 years of PSC, not yet PSCG, that Sinike occurred in 4.19 as opposed to 7.97 per 1,000 years in the untreated or non-PI eyes. So primary outcome occurred actually in 19 of the treated eyes post-PI and 36 during the 72-month follow-up that they had, mostly by development of PAS and not glaucomatous optic neuropathy. So they came up with an NT of 1 in 250 person years or eye years would benefit if we do a PI on all with PACS. So again the same thing, PI reduces the risk factor, risk by a factor of 2 is what they told us, but almost the same team, quite a few investigators being the same, did this analyst study as a follow-up on it. This is the symptomatic narrow angles laser iridotomy study. This is in Singapore, multicentric. And some of the factors which were considered limitations in the ZAP were taken care of. So here we had 480 individuals over 50 years, bilateral 2-quadrant apposition, PI in one eye and the other eye was a control. So it's control has got all the demography matched, and the outcome PAC, Sinike, or an intraocular pressure going up about 21, or PSCG or acute closure was defined at the start of the study. Again, most of them are Chinese, most of them were women, in the Singapore study also, 5% of the LPI treated went on to develop the endpoint in 5 years, as 9.4 went on to develop PSC in the control eyes. And the hazard ratio again it gives you that the PI gives you a half the risk as opposed to no PI, but it does not prevent closure in all the eyes. But they did come out one more thing, that the hazard ratio goes up with older participants per year. There's an increase in the hazard ratio per millimeter of baseline in intraocular pressure. As the pressure goes up, the hazard ratio goes up. So they were more likely to reach the endpoint or go on to develop a synechiae if the PI was not done. The number needed to treat for the whole group was 22. 1 in 22 would benefit. Okay. The risk of progression reduces by half, but the absolute risk of progression without PI is not very high also. From analysts, we know that the older age group and higher baseline IOPs had a higher risk of progression. So you would go for a PI in those, around the side of PI in those. And because the PSCS to PSC incidence is low, either watch or do a PI, both we are justified. PI does not prevent all closure, and even if we do a PI, we still have to look for progression in closure. It does not absolve us from need for follow-up of these patients. Thank you.
Thank you, Thomas.